Hello, this is An Nguyen, and I am a PGY3 at Anna Health Thompson Peak Internal Medicine Program in Scottsdale, Anna Health, Arizona. Today, I would like to present a case report of Miller-Fisher syndrome to you. It is a rare, uncommon variant of Guillain-Barré syndrome in a middle-aged female patient of mine that I admitted overnight while on in service not too long ago. So a little bit more about Miller-Fisher syndrome is also called Fisher syndrome. Is named after Dr. Miller-Fisher, who described it in 1956. It is a limited variant of ascending paralysis, Guillain-Barré syndrome. Miller-Fisher is typically presented with rapid developments of blurred vision, facial weakness, poor balance and coordination, and loss of tendon reflexes. Miller-Fisher is observed in only about 1% to 5% of all cases of Guillain-Barré in Western countries. The main difference between Miller-Fisher and other variants of Guillain-Barré is that the first nerve group to be affected by paralysis in patients with Miller-Fisher are those in the head, resulting in difficulty controlling eye muscles and balance. This case illustrates the potential for misdiagnosis based on rarity and such nonspecific symptoms of Miller-Fisher. And in this patient who presented with a history of atypical migraine like mine and psychiatric conditions, it could be mistaken for somatic symptoms if not carefully reviewed. Going into the history, so she is a 46-year-old female, past medical history significant for atypical migraine, depression, and anxiety, antiphospholipid antibody syndrome. She presented to the ED for acute onset of back pain, blurry vision, headache, decreased sensation of hands and feet, as well as the saddle area for about 5 days. She doesn't have any bowel or urinary incontinence, however. She was seen in the emergency room at the Mayo Clinic actually 2 days ago prior to the admission with me. She was treated conservatively with IV fluid, Toradol, antiemetics, but had no improvement of her symptoms at all. They're actually getting worse. She endures saddle numbness, like I said, numbness and tinglings of the tips of her fingers and tips of her toes, as well as her tongue is numb. She admits to having tonsillitis, treated 2 weeks ago, but that's pretty much it. No other infection, no recent invasive procedure or injection to her lower back that we know of. Her physical exam, she has pretty much unremarkable vital signs aside from slightly elevated blood pressure of 146/86. She was definitely tearful and in distress and complained of a lot of pain, definitely in discomfort. Her neurologic exam shows impaired vision of the left lower quadrant of the left eye, partial left facial weakness with inability to blink, and weak superior lid without ptosis. She also has mild lower facial weakness. She has normal tone and strength, negative pronator drift on both sides, pinprick sensation decrease from the ankle down, both sides of her lower extremities. She has zero reflexes on both of her patella. She has absent Hoffman on the left and the right, and absent ankle clonus bilaterally. For her hospital course, we perform multiple labs and imagings, but I'm just gonna go over the one that is pertinent to her case. Brain CT scan and MRI scan to rule out cerebral vascular incident was negative. Her chest CTA was unremarkable. Her lumbar puncture shows a notable albuminocytologic dissociation with elevated protein level. We did an MRI of her cervical, thoracic, and lumbar spine, and the lumbar region definitely shows homogeneous enhancement of the nerve roots of the cauda equina, linear enhancement along the ventral and dorsal aspect of the distal cervical spinal cord. We also did the MRI brain with orbits with and without contrast about 7 days after her admission, which shows multiple bilateral enhancing cranial nerves, including bilateral oculomotor nerves, trigeminal nerves, facial, and left abducent nerve. She also has enhancing upper cervical nerve roots as well. So if you take a look at the right side, I tried to capture the imaging of her MRI lumbar region and also the portion of her MRI brain with orbits as well. It's a little bit difficult to show all of the features and findings that we mentioned in the exam earlier, but it's just a good idea. This is actually the imaging from the patient that I get as well. So you can see the enhancement of the nerve roots, and I think there's enhancement of the oculomotor nerves in the picture as well. Below is the labs that shows the CSF fluid analysis with elevated protein level of 238. Otherwise, everything else is pretty much unremarkable. So neurology was consulted. We go over the finding of the neuro exam, and the diagnosis of Miller Fisher was made. She was initiated with high dose corticosteroid and plasmapheresis for five times. She came back with significant improvement in vision, facial weakness, and sensation of her hands and feet. She was discharged home to have outpatient follow-up with neurology. So when she went home, she still have a little bit of her symptoms left. There's definitely improvement, however, but we have to continue to follow up with her outpatient in order to know whether or not all of her symptoms completely resolved. So for the discussion, this is a case that illustrates a middle-aged female presenting with multiple non-specific complaints of paresthesia and weakness with past medical history. Could be confusing. It's significant for psychiatric disorder and atypical migraine. She presented 2 times to the ED prior to this admission for the same complaints within 1 week, and however both times she was discharged home with the instruction to follow conservative care. This shows how easily misdiagnosis can happen when there are other confounding factors in the history. A thorough neurologic physical exam is extremely crucial to determine severity and the extension of neurologic deficits. On a different note, this case also emphasized the importance of performing lumbar puncture for CSF analysis, as this is one of the very few lab tests available to diagnose Miller Fisher. Again, steroids and plasmapheresis remain the mainstay treatment for MS for Miller Fisher, which can potentially lead to complete resolution of symptoms. Further imaging or additional treatments can be individualized depending on how the patient responds to therapy. So in conclusions, this case, it's very important to keep in mind a broad list of medical differentials before ending with a diagnosis of somatoform disorder. Miller Fisher incidence is low and the symptoms can be very vague, but it's very reversible and significantly improved if diagnosed in a timely manner. Further research for classification criteria and more specific guidelines of treatment can definitely be useful to achieve desirable outcomes in which the patient could have meaningful recovery and symptoms resolve completely. I thank you so much for your attention, and I hope that you have a good one. Hopefully this case is interesting to you and add onto the variety of the cases for the ACP. Thank you so much and goodbye.